Alright, so part 2 of this whole OBGYN. I was talking about eclampsia and mag sulfate. And we use mag sulfate for a lot of things now, both in the ER and in the field. Or at least we should be using it more in the field. You know, we use it for our asthmatics who are refractory to a nebulizer. We use it for refractory VFib and VTAC. But that's 1 to 2 grams. You know, with eclampsic females, and this is the only thing that's going to stop the seizure activity, 4 to 5 grams as a starting point. I've seen numbers as high as 10 to 15 grams required to stop this seizure in this eclamptic female. So don't forget though that seizures in a pregnant female aren't necessarily eclampsia, right? Women with seizure disorders get pregnant. Also, there are a number of women who the strain and stress of being pregnant can lower their seizure threshold. We all have a seizure threshold. In fact, I've read a study once that said everybody will have 1 seizure at some point in their life. It may be absentia, lights are on, nobody's home. It may be general tonic-clonic type seizure. So don't forget that people have regular seizures. So history of the present illness. Do they have a seizure disorder? Are their feet, legs, hands, and face puffy and swollen? What's their blood pressure? Right. But keep in mind, regardless of the cause of the seizure, you got to ventilate mom. Right. Everything's pushing up on the diaphragm, and her tidal volume's smaller to start with, and then you throw in the fact that you've got musculoskeletal seizure activity. You're not going to have coordinated movement of the chest wall and the diaphragm. You got to start bagging them. Remember also their O2 demands are roughly 20% higher, so you got to bag them. Okay. Excuse me. An eclampsic patient, a seizing patient, goes to the closest hospital. Not closest appropriate. This is life or death for the fetus and mom. So even though, excuse me, someplace like Huggins in Wolfboro that does not have a family center, does not have a birthing center, their ER is set up to do emergent childbirths, but then they don't keep them. They don't, so, but they're still set up to do PALS and neonatal ALS and whatnot. So they go to the closest hospital. Now, mom's preeclampsic. She calls because she's got this crushing headache and her blood pressure's 200 over 110, and she's stable otherwise. Yeah, I'm going to bypass that closest ER that doesn't have a birthing center, that doesn't have good neonatal care, and I'm going to go to that hospital where she is going to, because these people in these outlying communities that don't have a birthing center, and I use Huggins as an example, those folks go to either Memorial in North Conway, which has a really good birthing center, or they go to Frisbee, and or Wentworth Douglas, or Lakes Region, etc. So I will take them there. I have no issue with that. If I'm 10 minutes from Huggins, and I'm 40 minutes to Frisbee, and they're stable, they're going to Frisbee. Mom starts seizing though, she's going to Huggins ER, and they can deal with the transfer after that. Now, one of the other issues that pregnant moms have is gestational diabetes. So, and some of these folks, unless they're getting prenatal care, they really don't know they have it. It's not like in my diabetes for EMS videos where we talk about they come in unresponsive and stuff. It's typically they're running 200-300. Certainly they can have emergencies with it, but the more out of control mom's blood sugar is, the bigger the baby's going to get. More calorie intake, more carbohydrate intake, the bigger mom gets, the more weight she puts on, which causes a whole bunch of issues as far as childbirth, right? And then the baby gets bigger, which causes more problems with delivery also. So some of these moms will end up on either like diet control, exercise control, drop a few pounds, burn off some of that excess glucose, or they'll end up on oral meds. And a percentage of them will end up on insulins. And then they have the baby, everything goes back to normal. So that's typically not something we deal with, but you could, right? Check a blood sugar. They have altered mental status, check a blood sugar, okay? One of the other questions I want to ask them, prenatal care. Have they had prenatal care? Because there is less risk if they've had good prenatal care. Now, this prenatal care may be a midwife, it may be an OB/GYN, it may be pediatricians involved. Any of that is good because they're screening the patients. They have the warning signs of things that could happen, right? They know whether they're preeclampsic. They know whether they're have diabetes at this point. They're on prenatal vitamins. If they are having a lot of trouble with morning sickness, right? It's being handled with good prenatal care. I also want to know if they've had an ultrasound. And what I'll ask mom is, hey, what did they tell you? I want to know how many babies and how many placentas. I also want to know where the placenta is. So I'll ask them, did they say anything about where the placenta is? Oh, it's on top, or I don't know. But if it's in a position like previa where it's over the cervical opening, that's usually a discussion they've already had because they're going to end up being a C-section. But I especially want to know how many babies. And remember that twins may have their own fetus, own placentas. They may share a placenta. So how many babies, how many placentas? The other questions I'm going to ask them. Drugs, alcohol, cigarettes. Cigarettes are a vasoconstrictor. And drugs, I want to know what drug, right? I want to know if this kid is addicted to fentanyl, addicted to an opiate, fentanyl, heroin, carfentanil, whatever it might be. Because this kid, and I want to know when mom last used, because if we deliver, first off, this kid's going to have some health issues to start with. And if we deliver this child and he is a heroin overdose, I want to plan for that ahead of time. And I am not giving this kid fentanyl. Fentanyl. I am not giving this kid Narcan. I'm not doing it. If you see an adult going through detox, if you've ever seen that, you know how sick they are. Neonates die from detoxing, okay? If you have an addicted baby, you have a heroin baby, that baby is going to spend anywhere from a month to 3 months easily in the hospital being weaned slowly off narcotics. Weaned slowly off narcs. You give Narcan, boom, detox. It can kill the kid. We're already behind the curve with this little child. So what do? We bag him. We just bag the kid. You can take a 20-year-old heroin overdose and not give him any Narcan. Just bag him and you'll save his life. We did that for a while at one of the hospitals I worked for. Instead of putting people into DTs and the puking, punching and all that stuff and the symptoms that go with DTs, we were just intubating them, putting them on vents and sending them to the unit overnight where the narcotic was slowly wearing off and they slowly woke up and it was a lot more gentle transition. But then we got to the point where we were doing so many of them, we had to back off of that again. But that's what you do with an infant. You just bag the child. I'm not putting this kid into DTs. Crack babies, fetal alcohol syndrome. Oh my God, these little kids are basically pickled, and their organs are not working right. Their livers have damage. If I have a mom who has that risk factor, right? She's an alcoholic. She drinks a pint a day, a fifth a day, a 12-pack a day, whatever it is. And she's just had her first contraction. and they're 6 minutes apart, I'm going to take her to a facility that is going to be better equipped to handle that child. So I'm 20 minutes to Huggins, I'm 20 minutes to Frisbee, an hour to the Elliott in Manchester that has a NICU, an hour to Portland, who has a great NICU. I'm going to the place with the NICU. This child's going to need a lot of care. Now, if mom's close to the delivery, of course, then I'm going to, I'm going to go to Frisbee, and they can deal with the transfer afterwards. But closest appropriate facility. So keep those things in mind. If you give mom Narcan, mom's 9 months pregnant and she's a narc overdose, the kid's getting Narcan also. So the idea behind Narcan is not to wake them up. That's never been, it's become the thing, but the original plan and goal for Narcan was just to get them breathing again. So I've got a 9-month pregnant female who's unresponsive with a respiratory rate of 4 and pinpoint pupils. I'm going to give her 0.1 of Narcan at a time and just get her so that she's breathing 10, 12, 15, 20 times a minute. And I'm going to put on, I'm going to bag her until she starts breathing better. And once she's breathing better, I'm going to put her on, some oxygen. But I don't want to just pound 2 milligrams into her nose and put her and the kid into withdrawal. Bad things are going to happen. So, do we see this? We don't see it so much in the field, thankfully. But Memorial sees these kids on a regular basis. That's the last, hospital I worked with a family center, and I did neonatal resuscitation there a couple of times. The course, neonatal resuscitation. And they do a really good job with it. But, luckily we don't see it a lot in the field. What are a couple of the other questions I'm going to ask? I want to know how pregnant they are, right? So, what's your due date? Today is February, March 5th. I'm due March 21st. Okay, so that's 2.5 weeks from now. They're 37.5, 38 weeks along. Great. So we've got basically a full-term baby. When was your last period? When did you get pregnant? I want to know those things. I also want to know gravida, parida, and abortions. Now, abortion's a touchy term with people. It is the technical term for a discontinued pregnancy. A spontaneous abortion is a miscarriage, okay? That is the technical term for it. And then, of course, there's mechanical abortions. But G and P, gravida, parida. So G is the total number of times they've been pregnant. And P is how many live births. So if this is their 3rd pregnancy, and they've had 2 live births, that's what we're looking for, right? 3 pregnancies plus 2 births plus this pregnancy, that's 3, okay? If they say, well, I've been pregnant 3 times, I've got I had 1 live birth, that means we're missing 1, and I'm going to ask them, what happened to the other one? And if they say, oh, I had a miscarriage, oh, I'm really sorry to hear that. How far along were you when you miscarried? Right? Because if mom is 3 months pregnant and she's bleeding right now, and she miscarried at 3 months before, then I'm going to kind of start thinking down that path. But if mom's at 8.5 months and she had a miscarriage at 6 or 8 weeks, I'm not worried. I'm not worried about that. She had a stillborn at 36 weeks and she is right now at 32 weeks. I'm going to be a little nervous about that. If she says she had an abortion, I want to know, bluntly, was it a clinical abortion in a hospital or a clinic, or was it, the old term school would be Mexican abortion, right? Was it a coat hanger? And people are like, oh my God, you can't ask that. Yes, I can, because I need to know the damage or the potential damage to her uterus. I also want to know, has she had a live birth since that abortion, right? Because, and this is not a political discussion on abortion at all. If you outlaw abortions, people will start doing these backyard Mexico type abortions. I mean, you drive across the border into Mexico, and I've been asked, hey, mister, you need a doctor? Right? Because they do. That's what they do. With the internet now, this 16-year-old girl who is scared to death because she's pregnant and her dad's going to kick her ass because of it, she and her boyfriend can go online and Google abortion. How do I do it? And, one of the ways they do it is they take a coat hanger, they bend it over, and they go up into the uterus and they just scrape around and pull, and they cause this disruption. The problem is you can scar this uterus. And if you have uterine scarring, you have a weak spot in that uterine wall. So 2 years ago, she did a backyard abortion, and now she's pregnant. When she's trying to have a vaginal delivery and she's having contractions, that uterus can actually tear open, and we end up with a ruptured uterus. And now this kid is still inside mom, basically floating around in the intestines. Not good. Not good. Emergency C-section, right? And this is why also I want to know about the live births. Were they vaginal deliveries or did you have C-sections? In the past, once you had one C-section, you always got C-sectioned because of the fear for uterine rupture. Now they're starting to do VBACs, vaginal birth after cesarean. But I don't want to do that in the field. I want nothing to do with that in a house or in my truck. That one I'm going to be a little quicker to transport and get off scene with just to be safe. So, how many times have you been pregnant? How many live births have you had? What happened to the other ones? Did you have any problems with your prior childbirths? No, it went great. My first baby, I was in labor for 2 hours and out it came. Crap, when did your contraction start? An hour ago. We're screwed because, the next one's going to come quicker. Now, let's define a contraction. The start of one contraction to the start of the next contraction. That's when you say, oh, they're 2 minutes apart. This contraction starts, ow, 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 it ends. There's a nice little pause. The next contraction starts, ow, ow, that's where you time it. You get to 2 minutes between contractions, you should probably settle in and get ready for the birth. Even if it's a first birth, that 2 minutes, childbirth is imminent at this point. If they tell you they need to move their bowels and they will yell out, I gotta shit, and try to head for the bathroom, right? Stop right there. I need to move bowels. You need to check for crowning because that head's probably in the birth canal. Okay, so OB kits. OB kits are a great thing. They do have lots of nice handy equipment in them. The little stockingette for the kid's head, because keeping their head warm is crucial after birth. Because they lose most of the heat from the top of their head. Should have 2 clamps. I delivered a child in the front seat of a car one night in November in the rain, and the OB kit had 1 clamp in it. Great. Lowest common denominator, right? So it should have either a pair of scissors or a razor blade, a razor knife for cutting the cord. And it's going to have all these, towels and sterile sheets and things. And if you look in your EMT book, it shows all these great photos of mom, laying back with her legs up and spread, and there's, one of these sterile sheets across her waist and breasts and one across each leg, and she's sitting on one, and mom doesn't want any of that crap on her. Not at all. 50 degrees, raining, cold in November, and mom was buck-ass naked in the front seat of this car, her shirt up around under her armpits, her pants off, and she was hot and sweaty and wanted nothing to do with any of that. Okay, so have your OB kit handy. I've been hearing some things lately about people saying, oh, you've got to transport mom and baby in a separate truck, so you need 2 ambulances. I like 2 ambulances in case one of them's critical, but I'm not separating mom, a newborn mom, from her baby for a 20-minute ride to the hospital, or even a 2-minute ride. It ain't happening. And there are now some baby papooses that are designed for transport so that you can put the baby skin to skin with mom, which is what we recommend. And in fact, the AHA, American Heart Association 2020 standards say, unless the kid needs resuscitation, the sooner you can get this kid skin to skin with mom and start breastfeeding, the better control they have on blood sugar, the better control they have thermogenically, staying warm, and don't forget, mom and baby are bonded together pretty close here, okay? So skin to skin. But anyways, so we want to start thinking about delivery at 2 minutes. Now, where do you want to deliver this child? I know a lot of people go, I want her in the truck because that's my office. I know where everything is. I don't think these people have ever delivered a baby. An ambulance, even a box, is a pretty small place for childbirth. You've got mom on a stretcher and she's wiggling her butt half off of it, and there's not a lot of room at the foot of the stretcher or beside the stretcher. I want to be in the house, as long as the house is clean and safe. Mom's on her bed, ideal. Lots of room around her. I can lay out my OB kit. I can have my bag, my PD bag, on the floor next to me. So if I need a BVM, I've got it right there. I got a glucometer if I need it, right? I've got my resuscitation stuff right there if I need it. I mean, resuscitation in the back of a truck's hard enough, right? So, living room floor, perfect. King size bed, oh, it's ideal, right? I mean, I worked in a place at a hospital doing intercepts where we used to go out to a neighboring town to one of this midwife childbirth centers on a regular basis. And resuscitation there was great because, or childbirth as a whole was great because you had a big king-size bed and dad could be sitting or leaning back on the headboard with mom holding her hand and doing his coaching, and the midwife's down there delivering the baby. And I got my crap set up because we used to go just kind of automatic if they had a concern about birth or if labor was taking long. And I just go there and set up my stuff on the other half of the bed, and it was great. So I'm a big fan of that. Having extra set of hands is good. I want my partner right there next to me. I don't mind having a second truck there to help me out. In fact, I kind of prefer a second paramedic on scene to help me out. Let's talk about that. I've had a lot of EMTs argue with me that childbirth is a BLS skill. And I agree. When it goes well, childbirth is a BLS skill. But when it goes south, you can't have enough skilled hands. It's a very emotional event. Mom's dying or baby's dying or both. You've got dad involved. You've got maybe mom and grandmom and whatever. It's ugly when it goes south. You do not have enough hands. I've done childbirths with 2 of us and had, out in the woods of Lebanon, Maine, and had things go south, and it's just me and my partner, and so I'm in back alone, and I don't have enough hands. Don't have enough hands. Even with somebody else driving, with just 2 of us, 2 patients who are both sick, don't have enough hands. I love having a second paramedic for childbirth because I can always cancel them. But anyways, and people say, well, women have been delivering babies for millions of years without your help, Kevin, you egotistic son of a bitch, right? But across from the East Kingston, New Hampshire Fire Department, there's a cemetery. And if you are in that classroom upstairs and you look out the window, you can see a full height cemetery stone, and then you see a little cemetery stone. And they have the same end date on them. It was a mom who died during delivery about 100 years ago or 75 years ago, whatever it was. So, death during childbirth for mom or the kid was a lot more common before modern medicine. You know, and we are part of that modern medicine. So, let's talk about normal delivery before we talk about some of the things that go wrong. The majority of deliveries go fine. Thank God. My daughter, who's almost a midwife, I mean, she's like 50 patients and 50 childbirths into becoming a midwife, training-wise, talks about C-sections, you know, and we do too many C-sections in the U.S. World Health Organization has some numbers that, you know, a modern society should have, you know, in the low teens for percentage, and in the U.S. we're like, I don't know, we're 2 to 3 times higher. And in the city of Miami, I think she said it's something like 80% C-section. Nobody's got time to wait around for childbirth. Come on. And that includes physicians. You know, these physicians have 3 or 4 or 5 or 8 patients on the floor all in labor or ready to go into labor. If there's any delay, boom, let's take it. That way I'm ready for the next one. Or boom, let's take it because I got a golf appointment. But the majority of our childbirths go fine. So I want to get mom comfortable. If she's hot, she's hot. The other thing I want is some privacy. Remember the first childbirth I went to, it was one of the, in the city I was working, it was one of the fire officers' wives. And so when the tone went out to that address, everybody knew. And so by the time I pulled up in the ambulance, and we had another ambulance behind us, there were 4 fire trucks there. And so there's like 12 or 13 guys all sitting in the living room, you know, kind of looking at mom. And I'm like, guys, come on. If it's okay with her that you're in the room, go up behind her head. Go on the other end of the room. Because I doubt she's going to be right now she doesn't care. But, you know, how many times does she let all 15 of you guys sit there and stare at her vulva, you know? So, I want some privacy at the working end of this mom. And if you don't need to be there, get out. So anyways, I want to make her comfortable. I want dad there next to her, or coach, or partner, whoever it is that's part of this delivery with her. I want my kit set up. And when she starts to push, when I see the head start to deliver, I want to put my hand on the top of the head, and I want gentle but firm back pressure on the head. In other words, we don't want the kid to just go and slam out an explosive delivery. We don't want that. Mom will tear. She'll have vaginal tears that can extend up into the vaginal vault. They can extend down into the rectum and the rectal vault also. Now she's got a vaginal rectal fistula, and that's not a couple of stitches to fix. That's surgery to fix. So I don't want that. None of us want that, right? So just a little gentle back pressure. And once the head delivers, there'll be a little, and it comes out to the neck. I've had moms actually go, oh, that's it, I'm done, I quit. No, you don't. We still got the shoulders to come out. Okay? So the kid starts face down, starts to turn as they come out, and in the old days, this is where we'd start suction with a bulb syringe. Don't do that. Right? So kid turns, and then first one shoulder, and then the second shoulder, and now the kid's in a V shape down to the feet. And mom, I don't want mom pushing at this point. Once the shoulders deliver, I just want her to take a breath, right? And the kid's going to go slide right out. So remember, they have no neck strength. So as the kid's coming out, I want to put my hand so that a couple of fingers are under the neck and the head's resting in my hand. And then as the legs deliver, I want to put a couple of fingers in between the lower legs and ankles and kind of grip onto the feet so that I've got good control over this child. Okay. Now we want to assess, well, first we want to start warming the child, right? So we got to dry him off. So nice vigorous rubbing with towels. Towel's wet, throw the towel away. You know, the kid's on the table, the kid's on the bed. Dry him off. We want